Hey everyone, and welcome back to The Explainer. Today, we're zeroing in on the strict technical requirements for radiographic positioning of the sternoclavicular joints, or, the SC joints. If you've ever actually tried to get a crystal clear, unobstructed view of this specific anatomy, you know for a fact it takes absolute accuracy. It's a bit of a puzzle, so let's break down exactly how to pull it off.
Really, this is kind of the ultimate anatomical challenge for this region. Think about it. How do you capture a perfect SC joint and completely isolate it from that dense vertebral column? These joints sit incredibly close to the thick bone of the spine. If your angles are off by even a fraction, boom, that spinal shadow just swallows the joint space entirely. So how do we actually isolate it?
Okay, let's dive into this. Here is our systematic approach for today. First, we'll look at the baseline PA projection. Second, the PA oblique using body rotation. Third, the PA oblique using CR angulation. And finally, evaluating the image.
All right, starting right off with Section 1, the baseline PA projection. This is our foundational straight-on method.
Okay, first things first, physical setup. The patient needs to be strictly upright with their shoulders adjusted so they rest in the exact same plane. Step 2, make sure that mid-sagittal plane is perfectly perpendicular to the IR. And step 3, which is actually absolutely crucial and standard across all our methods today, you want to center the IR right at the jugular notch and apply a strict 6 by 8 inch vertical collimation.
Now, here's a really critical nuance. Head positioning. It completely depends on what you're trying to capture. For a bilateral examination, looking at both joints, the patient's head must be looking straight forward, plain and simple. But for a unilateral projection, where you just want to isolate one side, you actually have the patient turn their head to face the affected SC joint. It seems minor that this slight shift makes a massive difference.
And for this baseline projection, we need to talk about the central ray. It must be directed perfectly perpendicular to the center of the IR, entering at the precise level of T3. T3 is your magic number here.
Oh, and let's not forget about breathing. For literally all the projections we're covering today, the instruction is exactly the same. The patient must suspend their respiration at the end of expiration. Having them hold their breath after breathing out minimizes motion and honestly gives us the clearest possible window to look through. Okay, so you've taken the shot. Now, how do you know if it's actually any good? For a baseline PA evaluation, you need to clearly see both sternoclavicular joints and the medial ends of the clavicles on the radiograph. If you did a bilateral exam, there should be absolutely zero rotation present. None. But remember that unilateral exam where the patient turned their head? For that one, you should actually expect to see a slight rotation in the anatomy. That's totally normal and correct for that specific setup.
But what happens if that baseline view doesn't separate the joint space quite enough? Well, that brings us to Section 2, PA oblique using body rotation, our first alternative method.
For this, we use two specific orientations. We use right anterior oblique, or RAO, when we're specifically looking at the right SC joint. And, you guessed it, left anterior oblique, or LAO, is for the left SC joint. The position just directly corresponds to the affected side.
Now pay close attention to this measurement, 10 to 15. 10 to 15 degrees. We are absolutely not doing a steep rotation here. The patient's body must be rotated just 10 to 15 degrees toward the affected side. That tiny rotation is all it takes to project that heavy vertebral column away from the joint.
Now what's really interesting here is how closely this mirrors our baseline setup, but with that one crucial modification. Step 1, patient is upright, shoulders in the same plane. Step 2 introduces that change we just talked about. Gently rotate the patient 10 to 15 degrees toward the affected side. And step 3, just like before, respiration is suspended at the end of expiration. Okay, the central ray gets a tiny bit more complex with this rotation. You're going to maintain that strict 6 by 8 vertical collimation, and you're going to keep the entry level right at T3. But because the body is rotated, the central ray now needs to be perpendicular to the SC joint that is closest to the IR. To actually achieve that, the ray enters 2 inches lateral from the mid-sagittal plane, specifically on the side that's elevated away from the image receptor. But hey, sometimes a patient just cannot physically rotate their body, right? When that happens, we move to Section 3, PA oblique using central ray angulation. Let's compare these two directly, just to ensure total clarity. In the body rotation method we just covered, the patient is physically turned 10 to 15 degrees. But in this CR angulation method, the patient's position does not change at all. They remain perfectly straight and completely upright, exactly like they were in the very first baseline PA projection. So here is that critical number again, 15. But we need to be super clear. This time, 15 degrees is the angle of the central ray, not the patient. You're letting the X-ray tube do all the work here.
Let's break this alternative procedure down step by step. Step 1, the patient is strictly upright with their shoulders in the same plane. Step 2, you direct the central ray from the side opposite to the one you're actually examining. And Step 3, you angle that central ray exactly 15 degrees toward the mid-sagittal plane. This specific beam angle essentially sneaks right past the vertebral column to perfectly open up that joint space.
All right, let's wrap this up with Section 4, Evaluating the Image. This is our final checklist.
So the crucial point here is that regardless of which oblique method you used, the success criteria are absolutely identical. Your sternoclavicular joint of interest must be dead center, and it has to include the manubrium and the medial clavicle. You're looking for a beautifully open joint space right adjacent to the vertebral column, with only minimal overall obliquity visible. If you hit those marks, you've got a perfect image.
I'll leave you with this thought. We've just gone over some incredibly specific degrees, exact vertebral landmarks, and really rigid collimation requirements. But seriously, ask yourself, if you miss these precise angles, what crucial diagnostic details in that tiny SC joint space might remain completely hidden behind the dense shadow of the vertebral column? In this field, absolute precision isn't just a best practice, it's literally the difference between missing a subtle injury and making the exact right diagnosis. Thanks so much for joining me to master these techniques today. Stay curious, and I'll catch you in the next explainer.